Sijbrands for this kind introduction. I hope I can live up to the expectations after this. You make my presentation much more difficult. I have prepared a much more simple presentation as announced. But one thing you were right. Here you see the Architecture Institute, and here you see the Erasmus Medical Center. This is the third largest hospital of Europe. And as you will notice immediately, I am one of the 15,000 people working there. My own mobility towards this event was rather limited. 2 minutes. So that's not something to impress you with. And what this presentation will be about. I want to talk about the problems that labor mobility brought to my daily work. And I'm not to the folks of ELM, I'm not complaining about labor mobility, not at all. But it really made our work much more difficult. But then I also want to talk about the solutions we came up with, and we are currently implementing them, and they will have effects on the mobility of the patient when the patient wants to meet his or her physician. And I will mainly talk about diabetes mellitus, and that's because diabetes is the largest healthcare problem of the present day. So it's important if you have diabetes, you are at risk for cardiovascular disease, for kidney failure, heart failure, cancer, almost everything you can think of. This is really a problem, and it is growing and growing. It's almost epidemic size in our population. We'll come back to that later. Of course, I'm used to talk to biomedical scientists and to physicians, and this is a completely different audience. It might be that I still added real medical slang. Please interrupt me immediately. I like that most because actually I'm used to it. At home I'm continuously interrupted. So please interrupt me immediately, ask your questions, and not save them for after the presentation. I would like to keep you all on board during the presentation. And I will answer all these questions during my presentation, but you probably get more. Innovation. We need innovation desperately in healthcare. And today we are treating our patients more and more with high-tech approaches and much more aggressively than we used to. We can cure much more disorders than 10 years ago. But it comes with a price. For instance, we pay the price of very dangerous and difficult to treat opportunistic infections. So we need a new construction of our hospital. Although we face large budget cuts in the coming years, we decided to invest in this construction. We need patients being in one room per patient. That will prevent the spread of these very, very dangerous infections. Our hospital will be built on the same spot. It will be smaller, so we will have less beds in the new hospital, meaning that we need to speed up curing these patients, having less complicated infections. That's one step ahead. If you do not experience an infection during your admittance to the ward, I can send you earlier back to home. So it looks like we're building a huge, very expensive hospital, but actually we think that we can make a profit out of it. Another example is the resistance to antibiotics of certain bacteria. And this Staph aureus can be resistant to penicillin, which makes its treatment, when you are infected with it, much more expensive and also less successful. More people die when you are resistant. You are infected by a resistant bacteria. But the other problem, the problem for our hospital is that when there's an MRSA infection on our ward, we need to close the ward, wait until all patients are gone, clean the ward. The approximate cost of this expedition is, on average, 70,000 euro. So one infection with MRSA, 70,000. I think that the new building is a very smart economic move. But there are other reasons to change the hospital as well. This is how my outpatient desk looked 10 years ago. I was writing these secret things about my patients. Like this, not telling them what I was writing. And they accepted it all. They thought, well, this is the physician, he knows what he's doing. We sit here, he's not watching us, not paying attention to me, the patient. I'm paying him, but he's not looking at me at all. So that was the situation 10 years ago. And of course, we could have continued working this way, but we thought, let's try it in a different way. Today, the view of the patient at my desk is this. The patient can look at the medical file, which is a screen in the table. I work on it. I make lots of typos, so the patient says, well, you're a typo again. It's all wrong. And then, when the corrected file is there, we go through the laboratory results, the discussion about it. And it works like this. Here you see a patient with diabetes and kidney failure in the last stage. Really very sick person. You don't know if you see him like this, but look closely. I put it in a look. What is happening? Do you see what's happening here?
Interaction. I think there's some interaction.
There's more interaction, but what's happening?
He's very much involved,
yes,
and not passive waiting.
Exactly. Actually, what they were doing in the past, they were complaining about that I was not paying attention, not looking at them. Let's turn around. This patient is not paying attention to me. He's only working with his file. In the research, we've noticed that self-management, being the manager of your own disease, results in much better outcome than when a gray-haired old doctor says to you, you don't even need to do this and that. If you manage your disease yourself, that works much finer. Why did I choose diabetes? Diabetes is a disorder of the carbohydrate metabolism. You have a shortage of insulin, which causes your glucose to rise in your blood. So hyperglycemia. And the hyperglycemia causes all these complications I mentioned on the first slide. It's a huge problem at the population level. 900,000 persons in the Netherlands have pre-diabetes. 800,000 of the persons have diabetes already. We estimated that between 30 and 50% of the patients are not diagnosed yet. So we have unidentified patients with a severe disease walking around without knowing that they are having diabetes. On a yearly basis, we approximately in the Netherlands diagnose 9% new patients with diabetes, although in Rotterdam it's 12.
Right. What exactly is pre-diabetes? Is that somebody with symptoms of diabetes or something else?
No, it can be with symptoms, but the symptom is like obesity. We call it, another name for it is metabolic syndrome. There are many names for disorders that we grouped into this group of patients with a kind of pre-diabetes. Actually, you are producing more insulin, your pancreas is doing its very best, and you are compensating all other susceptibility to diabetes. And at a certain point in time, in a large part of this group, this compensation mechanism will fail. And then you are part of this group of 9% stepping over to this group.
Why would Rotterdam have a higher?
I come back to that question to you. Next slide. Very good question. When we diagnose diabetes, already 50% has chronic complications. So we are experts in being too late in this disorder. And the total health expenditure is 2 billion. But the real cost to our economy, to our society, are much higher. Back to the Erasmus Medical Center, very close by. 2 minutes from here, we look at the patients with diabetes 8.6 times yearly. But in all other hospitals, 80 hospitals of the Netherlands, including the other university hospitals, they only look 1.7 times. So there's no problem at all. Erasmus MC is just completely inefficient. What do you think? Why are we looking so often to these patients? It has to do with something I told you in the beginning.
To prevent further disease?
I think we are too late in our population to do that. I would like to. Now it has to do with the size of our population. We are a university hospital for 4.3 million people. And we have a much stronger selection of the most severe cases. So we are looking only at end-stage disease. All these patients, almost 87%, already had at least one myocardial infarction. You will never find a population like this in any other hospital in Europe. It has to do with the strong selection towards outcome. But there's another reason, and you are close by. Can you come up with another reason? It's the same as why the growing prevalence is so high in Rotterdam.
I think it would have to do with foreigners.
Yes, exactly. It has to do with this. We have a very, very intercultural society. At our outpatient clinic, 17% of the patients hardly speak Dutch. They speak altogether 168 languages. And I like to speak languages, although I'm not that good at it. And the problem is that patients mainly speak languages I'm not very good at all. So it's Chinese, it's Moroccan, Turkish. So we're facing a problem there. We're trying to treat them very well. They take a translator with them. We have translators, but they don't want to use it. It's not personal to them. And then we talk to them. Don't know what has been translated. They leave. And year after year, they have the same results. We give them medication. The results are fully treated diabetes, which is totally unacceptable. So that's a real problem for the Rotterdam population. These persons get, compared to Caucasian patients, they get diabetes at a much younger age when they are less overweight. And when they have it, it's a much more severe disorder. So these are the persons we should communicate best with. It's
Erasmus
impossible.
Diyabet Ölçü İstasyonuna hoş geldiniz.
Here you see our solution, or at least part of it. This is my virtual diabetologist, Diabetologist 2.0. As he talk German or talk Turkish to you,
Willkommen bei der Diabetes-Messstation in Erasmus MC.
especially
Geben Sie zuerst Ihre Patientennummer und den Bestätigungscode ein. Wählen Sie danach die Messungen, die Sie ausführen möchten.
My diabetologist 2.0 at the moment speaks, is fluent in 10 languages, among it Chinese. And of course, she can speak the most beautiful language of the world, without any doubt. And she's good at Turkish, Arabic, and even in this very exotic language. Now, ICT offers you solutions in this respect, which are unparalleled. I cannot do that. And the machine helps the patient to take their own history, do their own physical examination, perform their own laboratory workup, checkout, everything in their own language, but also in their own cultural background. It's not only language. If you want to explain to a Moroccan patient that you want to do prevention, he doesn't understand what you're talking about. A Moroccan patient comes to a physician when he is very, very sick and has lots of pain. So what is all this fuss about? He's not sick at all, no pain. What are you talking about? So you need much more thorough education about these disorders. So it's not only a language, it's a cultural background that needs to be dealt with as well. The referring physician is very happy because the quality of his work will increase. He's educated to treat sick people and not to perform 3 monthly checkups without hardly any decision. So it will improve the quality of the work of my colleagues as well. This is the scope of my talk, because I've been showing this around so far. This is the first time. This is the next version of our virtual physician. It's the mobile variant, and we are building it right now. And what we cannot do is bring it into the houses. We cannot bring it into the house of the patient because that is much too expensive. But we can bring it close by. You do not need to visit our hospital to test yourself. And while you're testing, of course, we need to know if we can use these results. Is it with confidence? And we tested that, and what you see is that the systolic blood pressure and the diastolic blood pressure are in good agreement when the patient measures it itself or when we do it as physicians. And of course body weight as well. But even the patient is able to make a good picture of his own retina. 95% of the patients have pictures of their own retina. And we do that as ophthalmologic follow-up of the eye disease. Diabetics can become blind due to a response, a growing response in their vasculature. This is the same patient, and this was made by my assistant. And what you see is that there is interference due to the eyelashes. And approximately 60% of these 95% who succeed to make these pictures have better quality of that picture than we make, than when we make them. That's really something which we didn't do.
How do you explain that? How do you explain that?
I think that they take more time for it, and the machine is more like the webcam technology. You do not need lots of light, and we use these expensive, like such cameras over there, like Canon cameras, and they need more light. That's the difference, and they make small pictures, and they are fused. These are actually 5 pictures with software. They are fused, and we do not need medication to widen the pupil, and because then it would be a dangerous situation. and they need to drive home, widening pupils, and it will be a mess in our streets. So I think that the technology is different, and actually this should be the best picture, but we are working under time pressure, and the picture is, there's nothing wrong with it. I can judge it. This is a patient with 10 years, having 10 years diabetes. There's nothing wrong. It's a completely good picture. That's the good news.
What do we see here?
Okay. A tiny little bit of anatomy. This is the place, the papille. This is the place where the nerve goes out of the eye on its way to the brain. You do not see with this part of the retina. And the nerve and the vessels, the arteries and the veins are closely related. So here you see the large branches of the vessels coming in and going out together with the nerve. And this is the retina, this is the yellow spot. This is the place where you focus. You're looking right now to this slide, and your yellow spot is receiving exactly this light pointer. This is the part where you see sharply. This is your focus point. So this is the back of your eye, back wall of your eye. So to conclude, our modern intercultural society needs healthcare without language and especially not cultural barriers. The patient can be a very good case manager. The collaboration between the referring physician and the virtual physician, of course, is essential. The virtual physician needs to be programmed in such a way that when you are really sick, you will be sent back to the referring physician, and he will deal with it. And that's where he is exactly trained for. He's trained to deal with sick people, and he shouldn't waste his time with screening persons.
Is this system, this IT system?
This IT system that you have developed in the Erasmus University, do you share that with other hospitals or with other university hospitals?
We are currently in the process to implement it in the new model in the first line and second line of care in Rotterdam. Is that an answer? But of course, yeah, yeah. We just tested it here, and we are in the midst of going outside and using it in the wild. Is that question? So it should be a safe system, and the 2.0 variant shouldn't overestimate itself. The fewer visits to care providers is of course very important. If we do nothing and wait until within 10 years the number of patients has been doubled, I need twice as much diabetologists in my group, and that's already impossible to achieve because 10 years is not enough to educate them. So it's necessary to come up with solutions like this. And the whole project is aimed at doing more with less. Thank you for your attention.
We do have some questions, and maybe somebody from the audience as well. How much money do you save by implementing this at Erasmus?
That's a very difficult question. Firstly, the Erasmus population is not very suited to be tested and followed up completely by the system.
Right.
I think if you look to the Dutch population with diabetes, approximately 70% of these patients can receive full follow-up by the system.
Yes.
In the Erasmus MCA, I expect that we can reduce these almost 9 visits to 5 visits here.
Right.
Meaning that we do not need to enlarge our outpatient clinic, and we do not need to get more nurses, etc., etc.
But you have to have some guesstimate. how many costs you save or not.
Yeah, I think that,
Well, the hospitals are all about business cases.
yes,
so-
yes. I expect that we can do twice as much patients for the price we are paying right now. So
Alright.
that means that it's almost half the price. But I think that the economic figures are for the first line of care, the GPs, and the second line of care, the non-educational hospitals, are even much better.
All right. Yeah, I understand. And I had another question because he said, well, it's not only the translation of the doctor, it's also cultural backgrounds that they have another menu or something like that. So how do you interact with another cultural background in this system?
Actually, the software is built in a way that every possible answer is already available and is a movie. And of course, we thought it's so complex and big. We make text, but not all our patients can read. So we made movies. And so there's a decision tree, and then you answer the machine, and then you go in a certain direction, and the machine thinks, well, you're gaining weight again. And then in your Hindu diet, you get explanation about how to reduce your weight.
And how is that different in a Hindu way or in a, let's say, Belgian
The
way?
Hindus eat lots of carbohydrates,
Yeah.
too much. They eat, if we could remove rice from the recipes, I think
That would be
that would be
torture.
one big.
Yeah. So what you say in a Hindu version, probably you eat too much rice.
Yeah, we have a huge Hindu population in Rotterdam, and we already, with our 1.0 approaches, we already did that.
Right.
And all our Hindu, I think actually the best motivated patients, they are all going to the gym, and are all getting leaner, and actually there's no subgroup that's reacting that good on our approaches.
Right.
So it's a good example of that it can work, but of course in the Hindu community they realize that it is a huge problem, and they see very young people with kidney failure on dialysis. They see very young nephews, brothers, sisters being blind, etc.
Yeah.
So it's a big problem, and they are very motivated to get rid of this diabetes risk.
I'm really looking forward to a 2.0 version, mobile 2.0. When is it coming out? When is it ready?
The coming months.
Coming months.
Yeah.
Right. I'm watching.
Thank you.
Thank you very much.